before something important, before some meaningful associations begin to emerge. With the responsiveness in hypnosis, some of it may not be particularly pertinent, but one has to sort it out and allow more time. It does not always come about in the first or second session, and it may take considerable time before that material begins to form itself. It may be the second or third, but as you can understand, or as you heard, by the very nature of the response, by the nature of the experience, and more important, it is not the verbalization alone, although the verbalization contains the essence of what is being uncovered. It is also the abreactive quality, so that most of the material that is rendered under sensory or plasticine and sensory hypnotherapy has an abreactive element to it. There is a considerable loss of self-monitoring. There is a considerable loss of that kind of vigilance. And one might say, in a generalized sense, that vigilance is set aside very much during this experience. And therefore, as a matter of clinical judgment, it is not too hard to differentiate between that which contains a lot of vigilance on the part of the patient, even within hypnosis. And patients can be very vigilant within hypnosis when they need to be, or when they wish to be. On the other hand, when that vigilance is transcended, then the material that emerges is very clearly abreactive in nature. The second part of the question, or the second question, as I recall, had to do with the important issue of narcissism and narcissistic personalities. That, of course, is one of the more difficult issues to deal with in any kind of therapy, and I think in hypnoanalysis it can only be dealt with through the transference and by the patient moving from the level of self-expression in relation to the internalized conflicts which are now being revealed consciously to a very real direct confrontation with transference feelings. And I will perhaps tomorrow present some material which emphasizes how one can directly, after this first level of responsiveness has been met and there has been gains made, move into the level of the analysis of the transference. And it is only with the transference that that narcissistic component can be encountered. But it's a very good point. It's very difficult, and it takes considerable working through. It is the slowest part, I would say, of the treatment of most patients with this method, the narcissism. You have raised some very complicated questions, and they cannot be answered simply. And if I recall them right, let me take them not in the order that you presented them. The case of the nurse with such self-hatred and such self-destructive drives, which actually, and I didn't give you the full background history, there had been a number of suicide attempts on her part prior to therapy, which is why she was referred. Serious suicide attempts which had required hospitalization. Much of the origin that came out and took a great deal of time was revealed under hypnosis and did not necessarily involve the intensification of sensory experience, but simply the use of hypnosis for ventilation. And I would like to make it clear that even when one uses a specialized therapeutic approach, there is no reason not to depart from that at times to incorporate other aspects of therapeutic tactics or strategy, hypnotic and non-hypnotic. And I would like to add that very often non-hypnotic sessions are held interspersed when they are meaningful and things are discussed in a more direct manner, or other approaches may be used to integrate and to facilitate the therapeutic process. What came up under one of her sessions was a spontaneous regression to an age of approximately 15 years, when an uncle who was a dentist hired her to be a kind of dental assistant after school because he needed one and she lived nearby. And after dental hours, he would give her nitrous oxide, and then he would sexually abuse her under the nitrous oxide. And this went on for several years, and there was much abuse here. And one of the other components, which in the extract which I read did not go into that detail, was that there was an element of a multiple personality here. There were ego state fragments that would come up, and she would depersonalize at times as a means of coping with the terror and the trauma. And nitrous oxide in itself is a very interesting phenomenon in that it is both ego exhilarating, and one looks forward to the experience as one does to drugs. In many cases it is similar to the kind of high one gets from cocaine, and sometimes from marijuana, if one gets a relatively high from marijuana. But it also threatens one's defenses very much, and it is very frightening. And she was exposed to a great deal of this, and some of it had residues, so that characterized a good deal of her disturbance. In some of the instances you described, and I must admit I don't recall the full details, but the anxiety states that are associated with certain procedures, I think you made reference to eating spaghetti, but I can't quite connect that to anxiety in some ways. It's, unless one is anxious about gaining a lot of weight. But if the setting is one that precipitates anxiety, frequently that kind of problem responds much better to desensitization with hypnosis than to this kind of process. As I indicated earlier today, the use of a sensory hypnoanalysis is really limited to certain kinds of patients, and in essence, patients with long-standing characterological problems, where it is the character formation and the need to restructure personality elements, rather than where many obsessive-compulsive symptoms, as terrible as they are to deal with and as impairing as they are to a person's life, have a certain autonomous quality to them. And frequently, patients with certain obsessive-compulsive features do very well in other areas of their life except for this. And sometimes desensitization serves a better purpose than this kind of therapy and may even be more rapid in its effect. But with many compulsive disorders like hand washing, I think most psychotherapies, in my opinion, have not been terribly effective in dealing with this. One can modify it, but at the present time in the United States, which is the only area I can comment on, much better success is being obtained with psychopharmacology, and with a number of new approaches with psychopharmacology than with psychotherapy. And recently there have been a number of important seminars training psychiatrists to use psychopharmacology with this problem, because otherwise it is, as you know, very frustrating, and the results are not terribly good. I would not recommend hypnosis for this. I think the reconstructive aspects in psychotherapy with hypnosis, whether it be this type or whether it be a more traditional type of hypnoanalysis such as Wahlberg and Schneck have described in considerable detail, involves dealing with the very same issues that one would in psychoanalysis without hypnosis, and that is dealing with the Oedipal and Oedipal-like conflicts that have given rise to both the character structure and to the personality dynamics. The advantage that hypnosis may have, and I emphasize the may because it does not always lend itself to a shortening in these instances, is that it helps the patient gain access to the meaning of that. And I would like to answer your question in a different way, and I can do that if you don't mind my deferring until tomorrow. I have a tape of a patient with that kind of narcissistic problem, in which the Oedipal issues were paramount and which required lengthy personality reconstruction in his therapy. And this abreaction, which takes place for several hours, of which I have 2 tapes, we won't play them for that long, I think better answers the question. But in essence, it has to be dealt with at the very same level that it occurs and that you would deal with it in non-hypnotherapeutic approaches. And for that reason, I would like to qualify one point which I don't want to claim responsibility for, but which I share responsibility for with my colleagues, all of whom use hypnosis, because I think when, as hypnotherapists or analysts, there are certain ideas that are put forth. I think we have a joint responsibility to clarify these issues to other colleagues who either are interested in using hypnosis or may not use it but want to know more about it. There are therapies such as I've been describing, and which Devin Liu, an analyst in Montreal who does similar things without hypnosis, and who publishes the International Journal of Short-Term Psychotherapy, Dynamic Psychotherapy, emphasize, and that is that there are ways of very directly confronting the dynamics of a patient's neuroses and dealing both with the problems present and incorporating an analysis of the transference and utilizing countertransference issues in a much briefer period of time. And that sometimes very effective reconstruction of personality can take place in selected patients in sometimes 20 or 30 sessions as opposed to much longer therapies. On the other hand, I think it is a misleading idea if any of us were to promote the idea that hypnosis in general can shorten therapy across the board, because that is not generally true. Sometimes, and I think Wahlberg has made this very clear, that hypnoanalysis, and I think Wahlberg was one of the first people to use the term when he published his volume on hypnoanalysis in 1948, made it clear that it permitted him as an analyst to deal with many inaccessible issues in the patient in a more direct manner. But it didn't mean that it shortened the time of therapy. That in general, some psychotherapies with hypnosis are just as long as therapies without hypnosis. The only thing is, it may make it more accessible. It may make certain elements more accessible. Some of the strategies may be more amenable to that patient's personality dynamics. Other kinds of therapies, and I think both Professors Marquisens have emphasized that, and some of the material I've presented today has emphasized that we do have short-term therapies. But that does not mean that hypnosis in itself is short-term therapy. It sometimes is, when selectively used, a better form of therapy. On the other hand, although nobody has said it, I'm sure everybody would in general be in agreement, there are many times we see patients that we feel hypnosis is not the best indicated form of treatment, and we would prefer that they have some other kind of therapy. And the contraindications to the use of hypnosis are not that intense or that great, but they certainly do exist. And many patients do much better with non-hypnotic therapies, not necessarily because they're resistant, but because they will not be able to incorporate that aspect of the intimacy and transference which hypnosis implies. So that I just want to leave that with you as one element. Don't think that because we use hypnosis that everything becomes short-term. It does not. I would just like to add one comment. I think at one time we were very excited about the role of the endorphins and its mechanisms as neuroscience. I think today there's some very exciting work going on in neuroscience, particularly with regard to cognitive functions, and a great deal of psychotherapy in the United States, particularly under the direction of Professor Aaron Beck at the University of Pennsylvania Medical School, utilizing what is called cognitive therapy, has gained great popularity because of its successfulness. I think as advances are made in neurosciences as well as in other areas of the behavioral science, hypnosis takes on more meaning, even though it may have different meaning. I think we have learned more about the nature of hypnosis by contributions from non-hypnotic areas of science than we have from hypnotic experiments itself. And even as we talk about pain control, we are learning all the time that pain is a phenomenon which has broad parameters. And while hypnosis is meaningful in dealing with aspects of pain, the way in which it does so and where it does so and under what conditions are very circumscribed and very different from control by the use of pharmacologic agents. For example, a couple of years ago, we saw a young woman. She happened to be a psychologist, and she had to have a thyroidectomy. But she was very allergic to virtually every anesthetic that was available. And this operation was done at Mount Sinai Hospital in New York. She was a remarkably good hypnotic subject. She was sent to our center for assessment and to see if it would be possible to do it, because the incidence of being able to do thyroidectomies under a total hypnoanesthesia are not that prevalent, and it is a selective element, and it was a serious operation. She was a remarkable subject, and we decided, in collaboration with her surgeon, that it would be possible to do it. And we explored this for several weeks and prepared her. And in the operating room, there were two of us who were involved in her training. And of course, there was a normal complement of anesthesiologists available in case we ran into some difficulties, and they would do the best they can. But she had almost died from Novocaine in the dental office. In fact, she had been pronounced dead in the ambulance, but they revived her at the hospital. So that any amount of chemical anesthesia was a very dangerous threat to this woman's existence. I mentioned she was a psychologist only because, like many psychologists, she had a kind of morbid curiosity about things. And she said she wanted to watch the operation. So the surgeon erected mirrors on the ceiling so that under hypnoanesthesia, with her eyes open, she could watch everything that was being done. And I think you have to have a morbid curiosity to want to see your throat slit open and somebody working on it while you're on the operating table. One would much prefer not to watch this thing and just get it over with successfully. But she watched it, and we communicated with her. We had a large pad on a side table alongside of the operating table, and she would write out answers to what we asked her. How do you feel? And she said, fine. Are you comfortable? Yes. These are not direct quotes, but pretty close. Do you like watching the operation? I'm fascinated by it. And she gave us quite extensive descriptions to question. And she was very calm, and she was lying on the table, and they were doing their surgical work. Everything was fine. And then, as part of a procedure we had planned on, we used an automatic writing device in which we dissociated her hand from the rest of the experience consciously and indicated the hand was, as you know, with automatic writing, would now convey unconscious reactions, not conscious ones. We said, how are you feeling? And she said, and I quote literally, the son of a bitch is killing me. It hurts like hell. In other words, at one level, she was experiencing full pain, but this pain was blocked. And on a conscious level, she was comfortable and relaxed. And she didn't even have to be tied down to the OR table if it wasn't a procedure in the hospital. And the event went through comfortably. The point I'm making is, we should not be deceived to think because consciously the patient in hypnoanesthesia does not experience pain, that they are not in fact experiencing pain. We have done some other studies which indicate that, for example, giving patients large amounts of drugs like Serpacil, which impair cognitive functions and psychomotor functions extensively, that if you give them, and we've given them as much as 150 milligrams and 200 milligrams of Serpacil, and a week before they've gone through psychometric testing with a neuropsychologist, what we do is, after they get the injection of Serpacil, they have been previously hypnotized, and the drug is given to them in a hypnotic state. They are then put through the battery of psychometric tests again. We find virtually no distinction between their psychometric response and that which was done previously several weeks. The moment we remove the hypnosis, they usually collapse from the sudden impact of the drug. In other words, what's happening is the brain and the mind are delaying the onset of that drug through the intervening function of hypnosis. And I think, just to go back to the question, neuroscience is going to help explain many of these questions and will make hypnosis a clearer, if somewhat different, phenomenon in the future. I have to leave at the moment, so I will thank you for your indulgence. I have a very simple response to what I heard this morning. I agree with everything I have just heard. I say that not in a deceptive or elusive sense, but I think the progress that has been made in psychopharmacology as well as in neurosciences are obviously very helpful in treating a number of conditions, some of which may very well be organic in their origin as well as in their management. I think, for example, in the current revision of the DSM, the Diagnostic and Statistical Manual of the American Psychiatric Association, in the revised edition and in DSM-4, which will be coming out very shortly, in fact, preliminary issues are now available, panic disorders are now considered as organic diseases, not as psychological diseases, and that panic states are to be viewed as those to be treated primarily with pharmacologic therapy rather than with psychotherapy. A number of people, probably some of us, have seen patients with panic reactions and panic attacks, but that is different than a total panic disorder, and it has become increasingly clear that panic disorders will be found to be locused or centered undoubtedly in brain dysfunction, and in treating it, drug therapy is probably the first indicator and the best indicator. That is true also with certain obsessive compulsive symptoms, such as hand washing, which has begun to respond very well to a number of different pharmacologic agents. On the other hand, we have the interesting problem, which everybody faces, and many of you interested in psychopharmacology and certainly in neuroscientific developments are probably familiar with the work of Solomon Snyder at Johns Hopkins Medical School. He has done some of the initial breakthroughs with the endorphins and with serotonin for many years, and was at one point a candidate for a Nobel laureate, but he didn't make it, much to his dismay. He has, in very recent times, had a different view. In fact, there was an article published just about a week ago in which Dr. Snyder said that he is now less optimistic about the potential for pharmacologic action in terms of treating certain conditions, for the reason that sometimes the emotional states that we see produce alterations in serotonin levels and produce alterations in neurotransmitter activity, which is the consequence rather than the etiology of the problem. So that we really have a difficult situation which requires careful evaluation of patients. And I think very often the psychosomatic reactions to emotional distress produce all kinds of biochemical changes. Now, many of those biochemical changes need to be attended to and altered and changed. And pharmacologic therapy is clearly a positive and constructive indicator. On the same side, there are many individuals who are not good candidates for psychotherapy. I think anybody who's a psychotherapist certainly recognizes that there are many individuals who may be referred to their practice or for consultation who are not candidates for psychotherapy. They do not have the capability, either cognitively or in terms of their total personality integration, to be able to deal with a resolution of psychosocial problems and other problems which they fail to realize are significant in terms of their difficulties. For such patients, a simpler and more direct approach has been the use of medication. However, in a very recent seminar at the National Institute of Health just a few months ago, there was a consortium of psychopharmacologists, psychotherapists, neurologists, experimental investigators. And there is an increasing conflict in that follow-up studies with the use of antidepressants with depressed patients have failed to sustain a level of integration and a level of function which goes beyond the reasonable expectations that were first held. In other words, there is more disappointment at the present time in the long-term effects of pharmacologic therapy. That is not to say that many people are not helped, they are. But on average and in percentage and in comparing psychotherapy patients with patients on psychopharmacology, there seems to be not a benefit from one as opposed to the other, but they seem to be about equal. In other words, there are as many failures with psychotherapy as there are gains with psychotherapy, and the same is true with psychopharmacology. When you take a large number of depressive patients who have been treated with drug therapy, you find that after a period of time, a high percentage of them have relapsed, and that the depressive episodes are recurrent. That's true also with psychotherapy. However, there is a growing sense that if psychotherapy is effective, and if it is able to alter and change the lifestyle and the life involvement and the psychosocial elements in which an individual is involved, that the lasting benefits of that therapy tend to be more effective than that of drugs. On the other hand, I think many clinicians at the present time are more inclined to look on something which is called balanced therapy. And there is no necessary conflict between patients using some medication for a period of time and being in psychotherapy. And what has been found is that in the initial stages, very often the use of medication helps to motivate the patient. It gives them a sense of increased helpfulness. They do not feel so desperate. They do not feel lost. They do not feel helpless. And therefore, their motivation for therapy increases. And then after a short time, one can drop the medication. So I think there is really a need, and I agree very much with the points you've made, because I think they're not questionable. There is a need to balance and to integrate on an individual basis what goes on. On the other hand, there have been a number of studies in various centers in the United States which indicate that hypnosis, and it comes back to what I would like to begin a little while this morning, that hypnosis may significantly affect and expand the effectiveness of some medications. So that, for example, we find individuals who are taking antidepressants that if they take it and at the same time practice self-hypnosis, that there is a decidedly better result than if they do not use the self-hypnosis and the medication. There does not seem to be a conflict with regard to the two. There may sometimes be a conflict if a person feels they do not want any therapy and only want medication. That's a different issue. But certainly the use of hypnosis as a means of facilitating drug response is a very important one. And it really transcends the issue of psychiatric patients or patients with psychiatric or emotional illnesses. For example, a number of us have been working in recent years with patients with organic diseases, Parkinson's for one, multiple sclerosis for another, patients, of course, with organic terminal illnesses, cancer, leukemia. And we have found that one can potentiate the effectiveness of medication with hypnosis, so that, for example, it is possible with the use of hypnosis to increase the red blood cell count in patients who are undergoing treatment for cancer, particularly for bone cancer and for leukemia. And that the amount of medication that is required frequently becomes less. So that in a recent study, a number of Parkinson patients were seen who were taking various forms of dopamine as a means of controlling their tremors and some of their cognitive alterations which go with Parkinson's. And some of the side reactions to the medications, and in other instances, certainly with organic patients with cancer, are really quite severe. When hypnosis is employed productively, and when a patient is capable of utilizing it, and I always add the qualification that not everybody is a good candidate for hypnotherapy or for any other kind of therapy, but when they are, the amount of medication that is necessary can be reduced significantly. So that, for example, in a recent study which was confirmed with animal experiments, it was found that there are a number of new experimental elements which slow down the process of Parkinson, and that the amount of dopamine the patient requires is about 1/3 of what they required before in order to reduce and eliminate tremors and many of the other psychomotor as well as cognitive symptoms of Parkinson's disease. In a comparable study, it was found that the effective use of self-hypnosis comparably reduced the need. So that what happens, and it comes back to a very central issue, which is not what I'm addressing at the moment, but a little later on, is that hypnosis appears to have a stabilizing influence in terms of the central nervous system. As Orne and O'Connell at the University of Pennsylvania some years ago pointed out, hypnotic relaxation is not to be confused with simple muscular relaxation. That there is a totally different process that goes on which transcends or is beyond that, which is simple relaxation. Not that relaxation is not meaningful, it is. But I don't have a copy of it, but I would recommend that those of you who are particularly interested, that the study by Martin Orne and O'Connell, published about 7 or 8 years ago, I may have the reference here, which I can fish out for you a little later on. I do. I'll give it to you if anyone's interested. Indicates that the electrodermal changes that take place and some of the biochemistry changes that take place are significantly different in hypnotically induced relaxation than in relaxation without it. In a study which I participated in about 10, 12 years ago at the New York Medical College Hospital in Westchester County, we did a study with diabetic patients, with brittle, juvenile diabetic patients who were hospitalized. And we're all aware that diabetes as an organic disease has many psychologic and emotional correlates. People who are diabetic get upset by emotional things, and when they get upset, their blood glucose levels begin to change. Diabetic patients, even those on insulin, are really generally advised to try to avoid stress and conflict. Don't get too agitated, don't get too upset, because for some it can precipitate very serious reactions. For others,
possono precipitare delle reazioni particolari.
For others, there may not be too great an impact, but in general, I think most specialists in diabetes would agree that the emotional level of diabetic patients becomes biochemically kind of fragile, and they are easily upset, and when they're upset, there are significant changes that take place in their blood glucose functioning. We did a study with over 25 inpatients with severe diabetes. They were severe enough to require hospitalization for that period of time. With their consent and with the hospital's consent, we did a very simple study. Since they were in the hospital, we could use a catheter to monitor their blood glucose levels constantly, not just using a venal puncture and getting a measure of blood glucose, as might be done on an outpatient basis, but we could measure their blood glucose for 24 hours constantly and recording it. And what we did during this period at various times was we induced hypnosis. We taught these patients to use self-hypnosis for about 3 days before we began the second phase of our experiment. The second phase of our experiment was to use hypnosis to get the patients upset. This may sound counterproductive in terms of therapy, but we induced stress. We made them very angry, really angry. And I can tell you, one of my associates who was involved in this one case made the patient so angry that the patient raised his fist and punched the investigator and broke his nose. Now that's a lot of emotion. Now we were monitoring their blood glucose constantly through this, and in a separate room we had 3 people who were not involved in knowing the nature of this study. They were all diabetic specialists, and they were from a different institution. They were from downstate medical school. And they were in the monitoring room, and they were just watching on the graph the blood glucose levels. And we said, we want you to tell us when you notice what you consider clinically to be a significant change or a noticeable change in their blood glucose levels, and to mark the time down because it's marked on the graph. We wanted to connect that with what we were doing to these people and making them at times anxious, at times angry, but really upset. And they got very upset. When we finished 2 hours of this, we went into the monitoring room, and one of the physicians, very capable man, said, you know, you asked us to watch these blood glucose changes. But he said, there are no changes. He said, I don't think these are diabetic patients. He said, it's perfectly normal. Well, I said, there are medication, of course. He said, yes, but there were no changes. And we said, at this time, did you notice anything? No, we had the running record and we compared it. After several months of studies of this sort, to give you a very summary conclusion, we found that what hypnosis does in diabetic patients is to stabilize their affective states. In other words, it is hard to get them upset. And if you do get them upset, it's behavioral, and it doesn't affect their biochemistry. In other words, there is some kind of biochemical equilibrium which is maintained against stress, so that patients, these patients particularly, in self-hypnosis and utilizing hypnosis, could display the affect of getting angry, but their bodies did not somatize the aspect of getting angry. So that from this we have concluded that hypnosis is a very effective means of learning to moderate the physiology of our emotions without necessarily eliminating the expression of those emotions. In other words, had we given these patients large amounts of tranquilizers, had they been on a lot of Valium or Xanax or some of the other strong benzodiazepines, I suspect they would have been cow-like, and anything you do to them, they would just not respond to. These people were very responsive, they were very alert, they were very clear, but their biochemistry did not reflect the stress. They were able to tolerate that stress without these alterations. So that, coming back to where we started a little bit earlier, I think there is clearly a place and a role for hypnosis regardless of the other intervening variables that may be used in the treatment and management of all kinds of conditions. And we've been particularly gratified with the way in which hypnosis can be used in patients without psychiatric illness, in patients with hemophilia, for example, in patients with many other organic diseases, where it is possible, through the use of hypnosis, to stabilize their physiology, to stabilize their biochemistry, and to permit minimal amounts of medication to be used. In the way that Brzezinski and several others some years ago reported on the use of balanced anesthesia. For example, at the Hospital for Special Surgery in New York City, which is part of Cornell University Medical School, there is now a procedure which has become almost automatic. Whereas 15 years ago, when Dr. Albert Becher, who was the chief anesthesiologist at the hospital, initiated this, there was much conflict about allowing him to do this. And what he did was, and what he wanted to do, which he finally got permission to do, was to use hypnosis as a pre-anesthetic device with children undergoing serious and significant orthopedic reconstruction surgically. And what he wanted to do, and he worked with hypnosis as an anesthesiologist for a number of years, he was convinced that if he could use hypnosis as a pre-anesthetic, that he could use what's known as balanced anesthesia. He could reduce the amount of chemical anesthesia necessary. And after a few clinical trials, he was granted permission. Today, and I'm kind of jumping some 10, 12 years, today it is standard operating procedure at special surgery for children undergoing orthopedic reconstruction, where the operations last sometimes 6, 7, and 8 hours, and they're very long, and the amount of anesthesia that usually is required is both extensive and goes on for intensity as well as a long duration. They have been able to reduce, on average, the amount of anesthesia that a child needs for a 6 or 8 hour operation by better than 60% when they use hypnosis as a preoperative procedure. The Veterans Hospital, Veterans Administration Hospital, is now using this procedure in many surgical procedures, ranging from hernias to open heart surgery, in which, again, the term balanced anesthesia, which many of you may be familiar with, there is a period of 1 or 2 days of hypnotic training and the use of hypnosis by a trained person, usually an anesthesiologist trained in hypnosis. And as a consequence, and I'll give you the results very quickly and simply, both at special surgery and in the VA hospitals, patients with a wide range of surgical procedures can be operated on with, on average, less than 1/2 of the amount of anesthesia that is normally required. Now, as we all know, there is more danger with anesthesia than there is with surgery. Certainly in the United States, the statistics indicate more patients die as a result of anesthesia trauma than they do of surgical failure. It really doesn't matter if you're dead, but it is clear that the anesthesia trauma has two phases to it. One, in those individuals who are precarious medically, it can precipitate their death. In others, we have a condition which many psychiatrists have seen, and it's known as anesthesia trauma. Patients after anesthesia, prolonged anesthesia, are sometimes emotionally upset for weeks and months afterwards. They were not neurotic before. They're now very agitated, they're anxious, and frequently it is hard to deal with these problems. To give you an illustration, some years ago, I saw a young woman referred by her surgeon because following a relatively simple but prolonged appendectomy, she became extremely anxious and nervous. She was crying, she was frightened. She had all the characteristics of an anxiety neurosis. But she had not had these characteristics before, and her family physician, who knew her for many years, said he didn't recognize these symptoms, that she was not a person with emotional problems. She went to see a psychiatrist, and after 3 or 4 sessions, he said, "I don't find any evidence of psychiatric illness, but you have symptoms." And he wanted to put her on a tranquilizer, which she did not want to take. Her internist then suggested, well, maybe we can use hypnosis to find out why you suddenly become so nervous. So I saw her, and here I may run into a little problem with translation, but we'll see if it works. I saw her, and in the first session, I said, I would like to use hypnosis to do just one thing, because I'm convinced that the psychiatric examination you had was competent, and that I don't think you have an emotional or psychiatric illness, but I think something has traumatized you, and it's something that started with the surgery. She was a good hypnotic subject, and she was able to enter into a revivification. She went back, and as those of you who have had revivification experiences with patients, she relived going into the hospital, she relived everything, and she was describing it as if it were going on. And she's now on the operating table, and she's describing what they're doing and how it feels. And then she says, oh my God, they're going to leave me here. This is terrible. I will die. They're going to leave me here. She heard the surgeon say, okay, here's where the translation problem makes me. Okay, let's go home. Now, I presume OR jargon in Italy may be the same as OR jargon in the United States. What he meant is, we're finished, somebody stitch up this patient, everything is fine. She only knew that they wanted to leave, they wanted to go home, they were going to leave her lying on the table. Again, in hypnosis, even though one may have acuity for the perception, there is a childlike level of interpretation of the language. She wasn't able to see the more sophisticated meaning of this. When she remembered all of this after the hypnosis and we discussed it, by the next day her symptoms were gone and never recurred. This was obviously one of the forms of anesthesia trauma that are experienced. There are many other forms that occur with anesthesia trauma. As a result of this kind of experience, people like Cheek, who is an obstetrician gynecologist surgeon in California, operating room personnel are now trained to be very careful about what they say. Because a patient in anesthesia doesn't mean they don't hear. They may not remember much. And it is true, and some of the experimental investigations of interconversational activity under anesthesia indicates that many patients hear very clearly what goes on in the OR. They do not remember it. And it is sometimes difficult to retrieve it even under hypnosis. It depends on the level of anesthesia that was involved. To kind of go back to where I left off before this diversion, there are now a number of hospitals in the United States, particularly in New York, California areas, that are using hypnosis as a preoperative procedure prior to anesthesia and producing two generalized kinds of results. One, markedly less chemoanesthesia required during surgery. But even more significant, in follow-up studies with a variety of surgical procedures ranging on, I say, on one hand, from hernia repair to appendectomies to open heart surgery to complex vascular surgeries to resections, colon resections, it has been found that those patients who have a period of hypnosis prior to the operation and who use it as part of the balanced anesthesia and can take less anesthetic chemically, their recovery is faster, they have less pain post-operatively, they require less medication for post-operative pain, and they are easier to manage as patients by the hospital staff. The nurses particularly are the ones who made these evaluations. These patients are cooperative, they're not depressed, they respond better to medical procedures, and they follow medical regime better, and they require less medication. So that, although it may be a little far from the work in neurotransmitters and serotonin levels and some of the other important brain mechanisms that are becoming increasingly clear, for example, with magnetic resonance imagery, it is really quite fascinating to watch what happens to patients when you just talk to them and you're having a running image formation taking place. There is activity taking place in that brain. And we have some preliminary evidences that when you intervene with drugs or with hypnosis or any other variable, that there are changes that really take place in the brain, not just in our minds. So that I don't see any fundamental conflicts, but I have a feeling that hypnosis can prove to be more effective in collaboration with whatever neurophysiological procedures and whatever psychopharmacological procedures may emerge in the future, because I think one simply enhances and permits the human body to adapt better to whatever procedure, even surgical procedures, even diseases. So that, for example, again, not to prolong this issue, patients undergoing radiation and chemotherapy for cancer are helped immeasurably with the use of hypnosis. The nausea, the vomiting, and the anxiety that accompanies chemotherapy sometimes, as many of you know, can be very intense and very distressing. In most instances, they can be managed and virtually eliminated with the use of hypnosis and self-hypnosis, which is undertaken sometimes only a week or two before the beginnings of either radiation or chemotherapy. This is a commonplace clinical procedure today, and there's nothing new or unusual about it. And I would say that at least half the patients currently, at least in my area, receiving radiation or chemotherapy for cancer undergo, usually with someone on the hospital staff. For example, at Sloan Kettering Memorial Hospital, which is the Center for Cancer Research and Cancer Surgery, Cancer Treatment in the United States, Jimmy Holland, who is the chief psychiatrist there, some years ago initiated a program where, if the patient is agreeable, every patient has access to a staff member who will work with him or her with hypnosis prior to the surgery, prior to radiation, prior to chemotherapy. And when compared with similar cases where either the patient does not want the hypnosis or in other institutions where they're not using it, the reactions to radiation and chemotherapy are so different that one would almost say it should become mandatory, it should become part of the operative procedure. Almost all the side reactions to intensive radiation and chemotherapy are very manageable. So that, again, to go back to where we started, I don't see any fundamental conflicts in these areas. I think they're very exciting and stimulating areas for what becomes, in effect, collaborative and integrated procedures, some of which are psychological. And when we talk about things that are psychological, we sometimes almost forget that they're still connected to the brain. It's just another route into it. And that I think we have the opportunity for much greater collaborative and integrated functions in these areas. And the statistics hold up very well. There is a marked reduction in the amount of chemical anesthetics that are necessary and that are required for that surgical procedure. A very important point which you made is that obviously anesthesia is a very complicated procedure. And as much as anesthesiologists understand what they do, they all have great respect for the seriousness of inducing anesthesia in human patients. But the REM changes and the changes in the sleep cycle are undoubtedly one of the fundamental factors that can precipitate anesthesia trauma and trauma to the entire organism which then makes the recovery period much more difficult. And Dr. Peter Field, who did some work at the VA hospitals with procedures that I've described in terms of balanced anesthesia and the pre-surgical, preoperative use of hypnosis, also, as part of that procedure, changed and induced dreaming that would occur right after surgery, so that there is less, but still some, less alteration in REM activity, and one can alter and change that REM activity in order to maintain what would be the normal homeostasis of that patient. But certainly the evidence we have from the studies with blood glucose levels in severely brittle juvenile diabetic patients, with patients undergoing serious operative procedures, with patients with terminal illnesses undergoing painful and disrupting radiation and chemotherapy, that the intervention with hypnosis is both effective and in many ways dramatic for one reason. We know that it works, but I would be hard-pressed to tell you why it works. In other words, I think one of the things historically, and this becomes a little more philosophical than it does clinical, is that over the centuries, hypnosis has always been a debatable issue, whether it was with some of the ideas of Mesmer or pre-Mesmer, or whether it was with some of the feelings of the early analysts and Freud's position, and I'd like to go into that a little bit, just from a historical perspective, a little later today, this morning. Hypnosis has nevertheless persisted in remaining as a potent force somewhere in the healing arts, so that it is hard to find any place where modern medicine exists where there is not also the presence of hypnosis as an integral part of the healing process, despite controversies. And it is still very difficult, I think, to say with any degree of precision that we know why hypnosis is an effective technique, because you can do many of the things without hypnosis that we do with hypnosis. You can say the same things to people without hypnotizing them. The same language is available. You cannot transcend some of their resistances, that is true. And while we theorize and conceptualize about what it is, I think somewhere we must come to the fact that some of the evidence at this point is that hypnosis as a process, as an experience, has a stabilizing effect on the central nervous system. And in that stabilizing effect, one then can reach and get through on psychological levels more easily, sometimes, frequently. And apart from that, just that stabilizing effect has therapeutic value. So that even though I think many experienced therapists and clinicians would say, well, hypnosis itself is not a therapeutic procedure. And I myself have said many times, we don't treat with hypnosis. We treat under hypnosis. But nevertheless, that process, that experience, and I hesitate to call it a state because I don't think it is, but I do think it is a bond and an alliance and a very powerful relationship that exists when we effectively bring a patient into contact with us on a hypnotic level. And as I spoke yesterday, I think it reactivates some of the very early connections that infants have with their mother and with their ability to attach themselves. I think hypnosis is a profound process of attachment. And I think we all know what happens to people when they don't have attachment. Probably one of the most devastating emotional experiences is when one loses a sense of being attached, whether it's in a psychosocial sense, whether it's in a familial sense, or when it happens in traumatic situations, such as in war neuroses. In Vietnam, one of the great consequences psychiatrically was when men in combat no longer felt attached. They were not attached to their units, they were not attached to their commander, they were not attached to their officers. They felt they were on their own because there was such disorganization and there was such disarray. And the post-traumatic disorders, the post-traumatic neuroses that resulted from that conflict are much greater than those that we've encountered in World War II, where our records are more adequate than from previous wars. So that attachment, in my opinion, is one of, not the only, but one of the important ingredients that takes place when a positive emotional experience, which we describe as hypnosis, is evolved and evolving for a person. And this tends to stabilize a great deal of what goes on. And a little later on, I'm going to describe a study which we did for 2 years, which is almost contrary and in contradiction to everything that I think I would normally say and that you would normally say and think. We all agree that hypnosis should be practiced by people with a great deal of clinical experience in their own professional discipline and adequate and competent training with the use of hypnosis. I mean, that's a sine qua non. That's what we say. We believe that, and it is true. I think hypnosis is most effective when it is used by professional people who are competent in their own discipline. That to learn hypnosis as a substitute for medical competence, for psychiatric competence, for psychological competence is no substitute. I think that's a truism that we agree with. The experiment, the study, it's not really an experiment because it's not well controlled. A clinical study, which in a little while I will go into with you, flies in the face of that fact, deliberately, purposely. What we did was, and I won't start it immediately, but I'll give you an idea of what it involves. We deliberately took a group of patients who had not been responsive in previous psychotherapy in a variety of centers and places, and we exposed them to hypnosis, and very simple hypnosis. And I'll describe the procedure when we get into the study, but not by trained therapists, by graduate students who had learned to use hypnosis a couple of months before as simply part of their training in a doctoral program in clinical psychology. They were not therapists. They had no clinical experience. They had very little expertise. They were told and they were trained to do one simple procedure, which again I'll describe when we get to it. And they did it. And they did it with patients who were not told this was treatment. They were told this was the preliminary stage for treatment. In other words, they would be accepted for treatment at the center by a therapist once they went through this training period, a little bit like autogenic training. They were told that this was a process that was necessary before they could be assigned to therapy. And it's a little disappointing in some ways and a little confusing in other ways. But by and large, these patients did very well. They got better. They got better in the hands of untrained therapists who were using hypnosis. Now, we used a control group, the same kinds of patients. Remember, all of them had previous therapy and been failures. Most of them were some cessation cases. And we had them see other graduate students, but they didn't use hypnosis. They just talked to them. They just asked them, you know what bothers you? Just simple ventilation. They didn't get better. They had the same amount of time. Which means, at least from that observation and from others that we have collaterally, that despite, the fact that we say the opposite, there may in fact be a very stabilizing, homeostatic phenomenon that accompanies the effective use of hypnosis and the experience of hypnosis. And for that reason, there is probably more than meets the eye in terms of what happens when somebody enters into hypnosis and has that sense of attachment. And it is that attachment, for whatever it totally involves, that undoubtedly plays a role in regulating, in maintaining, and in stabilizing not only one's emotional state, but the underlying physiology and biochemistry of that emotional state. So that in effect we're dealing with a process which is a developmental and maturational one. And that hypnosis does apparently have some unique properties. What they are, I'm not really prepared to say. We can speculate about them. And as I said, I speculate about them in terms of the hypnotic transference, the alliance, and especially that feeling of attachment. But one of the reasons why, undoubtedly, hypnosis has survived as a healing tactic in the whole era of scientific medicine in all cultures is that it does have some unique properties. And I think those unique properties require more careful understanding and evaluation and incorporation into a variety of treatment procedures. So that hypnosis does have some very real value by itself. And I think its potential is much greater in the hands of well-trained, competent clinicians. But by itself, it is a positive experience and is used in many non-clinical situations in cultures which have more a religious orientation, so that the use of meditative procedures and others have obviously beneficial characteristics. Made the call, made the appointment for 8 o'clock in the morning. I said, "Do you feel well enough to drive home?" He said, "I feel better than I've ever felt." And he got up and he walked out as if he were going on a tennis court. I said, "Call me from home, I want to know how you feel." He called me from home, said I got home, had no trouble driving. He said, "I'm going to cancel that appointment with my doctor." I said, "Don't cancel it. Do me a favor and keep it." What he told me the next time I saw him, which was a week later, he said, "I didn't have a bit of pain until I walked into my doctor's office, and then it was exactly the way it was in your office last night. It all came back again." He did have a herniated disc, and he eventually had to have surgery for it. They had to do a spinal fusion. He had really traumatized his back. Now, the sequelae to the story is the hypnosis worked very well and was a very effective intervention technique. After his surgery, when I resumed seeing him, he said, "Well, now that I'm such a good hypnotic subject, maybe we can make more progress in therapy and we can use hypnosis." I said, "Of course." He was no longer responsive to hypnosis. In other words, the demand situation is what created the change in his defenses and resistances. When he really needed and could put himself in a position of relinquishing that kind of control,
l'inconscio del soggetto aveva più giudizio.
he could then do it. Otherwise, he could not do it. And we made no further attempts because it just was not going to work.